on behalf of the Nova Southeastern University Alumni Relations Department, thank you all for joining us today for our Lunch and Learn featuring our NSU alumna, Dr. Julia Valente. Dr. Valente graduated from the classes of 2007, 2011, and 2021. Today, she will present on integrated counseling for co-occurring substance abuse and eating disorders. We are extremely grateful to have Dr. Valente here with us to share her expertise, experiences, and insights with the NSU community. For those of you that I haven't had the opportunity to meet yet, my name is Emily Lopez Martin, and I serve as the Assistant Director of the Alumni Relations Team here at NSU. I'd also like to recognize our Alumni Relations team who helped make today possible. Sarah McKenney, our Director of Alumni Relations, who is not here today, sadly. And then we also have our Jessica Hall, our Community Advancement Liaison and Photographer Extraordinaire, who will be capturing today's events. Our Lunch and Learn series was created to bring together alumni, faculty, students, and friends of the university, both in person and on Zoom, for engaging conversations that showcase the incredible talent and thought leadership that we have within the NSU community. And then now it is my pleasure to introduce Dr. Melanie Irucci, Chair and Professor of the Department of Counseling in the NSU College of Psychology. Please join me in welcoming Dr. Melanie Irucci.
Thank you so much. Thank you all for taking time to be here today. I know lunch hour is precious, so thank you so much for being here and sharing this time with us with Dr. Valente. It's my pleasure to provide Dr. Valente a proper introduction, I'm going to say this afternoon. Dr. Valente is a licensed mental health counselor, qualified supervisor, counselor, educator, and clinician specializing in eating disorders, co-occurring substance use disorders, trauma, and women's mental health. She's an alumna of Nova Southeastern University, where she earned her Doctorate of Education degree with a specialization in healthcare education and human services administration, and she earned her Master's of Science in Counseling degree. She is currently completing her second doctorate. Moment to just give that a nod. And she is a PhD candidate in counselor education and supervision at Walden University. We are so privileged to have Dr. Valente serve as an adjunct faculty member in the Department of Counseling in the College of Psychology at Nova Southeastern University, where she teaches a variety of both content and clinically based courses. She also maintains a private practice in Juno Beach, where she works primarily with women experiencing eating disorders, disordered eating, body image distress, childhood and adult trauma, sexual trauma, substance use disorders, relationship issues, life transitions, and broader mental health concerns. Dr. Valente believes deeply in healing through connection, compassion, and community, and she offers both individual counseling and women's healing groups. In addition to her clinical and teaching roles, Dr. Valente has participated in advocacy initiatives, including World Mental Health and Eating Disorders Advocacy Day at United Nations in New York and Eating Disorders Advocacy Day in Washington, D.C. So without further ado, please help me in joining Dr. Valente for her talk today.
Thank you so much. I was thinking while Dr. Irucci was talking, I thought, wow, that's a really long bio. I could have just said, hey, here she is. So thanks so much for everybody for being here. I'm Julia Valente. I'm so grateful to be here. I'm grateful to be here with you. I'm grateful that you showed up. I'm grateful to have any discussion about mental health, always. You know, when we show up for any discussion, that's advocacy. Anytime we talk about it, anytime we show up for it, that's important. So today we're going to talk about specifically co-occurring eating disorders and substance use. Both of those deserve their own presentation. Both of those deserve their own discussion and advocacy. They are high on the list of co-occurring. And so all of us as clinical mental health counselors, as professionals in the mental health field, we all need to be educated here on both of these. And their co-occurrence is high as we're going to talk about it. And so we're just going to blend this together. And I try to include also references and community resources for everybody as well. So just a little bit about eating disorders. I think on the whole, we often know less about eating disorders than we do about substance use. We tend to more comfortably talk about substance use than we do eating disorders, actually. And I think there's a lot of reasons for that. But just a little bit, the DSM-5, which is where we gain our diagnostic criteria from anorexia, bulimia, binge eating disorder, which was added in the latest DSM-5 in 2013. ARFID, avoidant restrictive food intake disorder. That's a very underlooked eating disorder. We used to think about it just in childhood and adolescence. However, it occurs quite often in adults. It's one of the eating disorders that's not associated with body image and food. It has to do with fear of food. And then it also coalesces sometimes with things like orthorexia, which is another eating disorder not currently in the DSM, which has to do with eating clean food or only organic or only green. It has to do with exclusion, closely tied with anorexia. ARFID is often tied with that as well, and or associated with a food trauma. Like if you had an incident with choking or you had another associated trauma and it would have affected there. The fear goes on to the food. Pica, which is one we don't often talk about, which is eating non-food objects like cotton balls or pencils or things like that. Not infrequent. Rumination disorder, ruminating about thoughts of food, ruminating about food disorder, that's often a co-occurring disorder. And then anything that doesn't fit into this, which is most times, is OSFED, other specified and unspecified feeding and eating disorders. I'm going to note that we diagnostically categorize individuals with eating disorders for insurance purposes, for payment purposes, for trajectory of service, for predominantness of symptoms. But the truth about eating disorders is that they're all mushed together. So oftentimes a person will in and out through their lives, anorexia, binge eating disorder, bulimia, and kind of go back and forth in different parts of their life, different stages of their life. We overlook tremendously the different stages of life for eating disorders. We think about it as young, we think about, think about the stigma that we have. The stigma that we have couldn't be further from the truth for eating disorders. They occur in all stages of life, from when we are in our like if we're in our 70s, we're in our 80s, we're in our 60s, our 50s, our teens, all through stages of life. And usually the advent is during transition. So puberty, for instance, is easily, right? Or a job transition or breakup of a relationship or menopause, perimenopause, change of life, children leave. They usually occur as a transition as a piece of a coping mechanism. There are serious biological, biopsychosocial, spiritual issues involving disturbances in eating and body image and emotional regulation and so much more, trauma. They're across, as we said, all genders, all races, all ages, all cultures. And I think one area, right, where we are trying to do a better job is the cultural diversity and age diversity and ability diversity in eating disorder research. Because I think that we sometimes, even as professionals, fall into a bucket of stigma. We stigmatize our own patients. We stigmatize our own concept of what they are, and we don't recognize it in other individuals who are suffering. So I know that for the mental health professionals that are listening, that are here, and the people seeking mental health, we don't all need to specialize in this, but we absolutely all need to know about it. We need to know about it because we need to know how to recognize it, how to talk, how to help, how to refer. We need to know about this. The possibility of not having an eating disorder and substance use claim is pretty low, actually, right? So even if we don't feel equipped to fully treat, we 100% need to know. And as community members and loved ones and individuals, we also need to know. We need to know how to get help maybe ourselves, or how to identify that, and we need to know how to help somebody else and do it as well. So it's important to talk about. We're just going to move right in to co-occurring substance use and eating disorders. So I'm going to point out that statistics are always low. So I quote statistics for just meaning of conversation, but the truth about statistics, really all statistics, are based on things like recidivism in treatment, meaning people come back and forth to retreatment, so they're gonna count those numbers, research numbers, right? Things like that. Statistics are always gonna be off, and they're most likely always gonna be low, and these are low. So 50% of individuals with eating disorders misuse alcohol and drugs, and that could be because substance use is a primary, it could be because it's facilitatory, it could be that it happened afterwards. 35% of individuals with substance use disorders also experience eating disorders. Again, my guess is that's pretty low, and from my professional experience, that's pretty low. Only because it has a way, both of these disorders are ingenious and they have a way of disguising themselves. Why? Because the disorders themselves, the illnesses themselves, are so severe often and so deadly that, and they don't exist necessarily in the cerebral cortex. They exist in the limbic system, and so they themselves have ways to protect themselves. And so the way that a person presents as secretive, right, to hide the disorder, to protect the disorder, so they're very, the co-occurrence can be much higher than that. Substances may be used to suppress appetite, numb emotions, reduce shame, increase energy, cope, trauma, or facilitate purging. So we think about bulimia as the act that we're thinking about as purging, but the truth is that think about all the ways that a person could purge, including exercising, right? Including activity. That's bulimia as well. So it's the body trying to move from that. So oftentimes substances can be facilitatory for that, from everything from, you know, anything that you can think of, enzymes to other kinds of drugs, to harder drugs, to other things that can make a person either facilitate their anorexia or their bulimia. Common co-occurring substances, integrated treatment is critical. So that's whether you are a mental health professional in this room, a student in this room, a loved one in this room, maybe looking for treatment for yourself or for someone else, finding professional, being a professional that can treat both disorders and really investigating that. The truth is about our field, a lot of places will say, yes, I treat both or I do that. That's not necessarily true. Right? They don't necessarily do both integrated one. Even though research supports integrated and meshed treatment, oftentimes it's a parallel treatment. So even if a person's at a treatment center for them, oftentimes they don't have the same therapist or they don't have treatment that is integrated in it. The impetus, the nucleus, the foundation for both these disorders is the same. The way in which their cognitive abilities, the physiological aspects of it, the neurological centers, the nucleus and compass, the limbic system, the way that it is operates the same, which is why they co-occur so often, and they're often being used for the same purposes, which is to try to be okay, right? Just trying to be okay. That person is just trying to be okay. Just trying to live with the trauma. Live with the pain, right? A person with an eating disorder literally is threading emotion through body image, or through fear, or through eating. Instead of saying, I feel afraid, I feel something about their body, right? Or this clothes don't fit, or, you know, they're threading something through that. Why? Because it's a lot easier to say something like that than it is to say, feel afraid, or I feel sad. Right? And so our job as mental health professionals is to help a person get underneath that. So the reason we all need to know, no matter what you're going to specialize in, is because a person with an eating disorder or substance disorder is going to come into your office or into your home or at your dinner table, and they're going to want to talk about body and body image and clothes or substances or food. They're talking to the disorder. Talking to that part of that person's mind and heart that is ill, instead of helping them with their emotions and underneath. So getting underneath that takes skill, takes conversation, takes training for sure, but it's always the same as any other kind of counseling. It's always about what's behind the behavior that is presenting. That is counseling 101, right? That's what we all do. So getting underneath that is particularly important. So the way that we talk to our clients, the way that we talk to our loved ones, the way that we talk to ourselves is really important. So talk a little bit more about that. Anorexia and substance use disorders such as opiate addiction have the highest mortality rate for any psychiatric illness. The highest mortality rate for any psychiatric illness is shown there. And that is, and again, even higher than what research is. Why? Because the death certificate doesn't say died of anorexia. The death certificate says that person died of a heart attack. The person doesn't say I died of alcoholism. The death certificate said died in a car accident or died in a fall, right? Or died of a esophageal cancer or died of, so many things, right? That we can attach to these disorders. So again, so much higher, but representing that. And part of that solution is us. Part of it is that we have to talk about it. We have to say it out loud. We have to inquire. We have to not look away when it feels like too hard to help someone. And that's us as mental health professionals, and that's the community. Part of it's us. Because these are very difficult. They're difficult to talk about for lots of different reasons. And they cause a lot of countertransference for us as well. And a lot of transference, meaning they trigger us, our stuff, right? Our body image, our food stuff, our being hurt by some of the substance use, they trigger our stuff. The behaviors that happen, feel like that person is doing that too, as opposed to an aspect of it. So, and really, really important. Most disorders report co-occur. Obviously, the mortality rate is higher. So eating disorders and addictions often share underlying genetics. So it's really important too. It's not a choice. It's not a choice. It's not a choice. It's not a choice. It is a brain disorder. Both are brain disorders. So they have a genetic predisposition that is always a precursor to it. And then they have a real perceived trauma, some sort of traumatic experience in life or a traumatic event. And then they have opportunity. Right? What's the difference between a 22-year-old heroin addict and a 60-year-old alcoholic? Opportunity, right? When that 60-year-old was 22, heroin was expensive and not available. Now it's cheap and on the streets. Opportunity, no difference. The trajectory of treatment is different. But it's really important to remember, right? To normalize this. These are brain disorders. So the things that people are doing, they're saying the way that it presents, these are not choices. And the further that the person progresses in their disease, the further that the disease moves from the cerebral cortex, which is where we make decisions, where we have rational thought, I'm sure you'll know this, into the limbic system. And then you don't have discernment, right? You have the sympathetic and parasympathetic nervous system that says fight, freeze, survive. And so that everything feels survival based and feels desperate. And that's where we see those really desperate behaviors and the secrecy. But what's underneath that for an individual? Shame. Shame and pain. And the further it progresses, the darker that it gets. Really, really important, worth its own presentation, the cultural inclusivity. Very important to remember that it is absolutely not just what we've been, have the stigma in our mind. A lot of that had to do with racial components, to be honest, and a lot of that had to do with affordability of treatment. Thanks to advocacy, thanks to pushing Congress, thanks to lobbying, insurance now covers, partially, treatment for substance use. 7 years ago, before the Anna Weston Act, before a lot of the lobbying with Congress got really ferocious, eating disorder treatment for a 30-day treatment was about $60,000. Private pay. Now it's not great. I mean, it's still expensive, but insurance covers it. Insurance also, as of 5 years ago, covers nutritional therapists, because on eating disorders and substance use, but particularly eating disorders, kids and teens, So you have a nutritional therapist trained in eating disorders. If you have a loved one and you're looking for a therapist, make sure that that nutritionist is trained in eating disorders and services. A mental health professional trained in eating disorders and substance use, a doctor, and usually a psychiatrist and reviewing them as well. So it's getting better. It's getting much better than it was, but a lot of that stigma is because that population that holds that stigma could afford it. And so a lot of that is emanates from that. There's a larger cultural diversity story there, but a lot of it had to do with money. So individuals of all ages, all economic status, professional employment, sexual orientation, age, ability status, mental and physical, neurodiversity, body shape, body size, even in our own field, race, ethnicity, religion, cultural and gender identification, even in our field, even in the eating disorder corner where I live clinically, there's stigma. And there's body shaming, and there's misdiagnosis and all sorts of separation of treatment. So we all have a lot to grow here and to talk about. Efficacy of treatment, again, is always about dual treatment, always at the same time, the same therapist. Because what's underneath the substance use is not different than what's underneath the eating disorder. It's all what's underneath the human being. So the human being being treated holistically is really the human being with substance use or human being with an eating disorder. Just want to go over, just have a few slides about for individuals that can ask. If you're looking for a therapist or a mental health professional or mental health professionals in the room and on Zoom, one of the most important skills that we have is motivational interviewing skills. One of the most important skills that we have. Why? Because of the shame and because anytime we confront or try to control, that's going to reduce participation in therapy. And also motivational interviewing is one of the most important therapeutic skills that we have that is culturally inclusive. Why? Because that person is defining where they're going to drive. That person is defining that we're merely the guide. We're merely the person with a light that says, you know, what I hear, like, what do you think of this, right? And so, but they get to decide there. So it's a really important skill for us all to have. For co-occurring substance use and eating disorders specifically, it was actually designed for substance use for resistance. Because in substance use and eating disorders, high resistance from clients. Fear, like who would it be afraid, right? It's what they're using to survive. It's what they're using to be okay. Why in the world would they not be afraid? Why in the world would they want to give it up? It's what they used to be okay. So of course we're going to have resistance, right? And we know as mental health professionals, never do we meet resistance with resistance, right? And so motivational interviewing is a really important. It was designed specifically to help that individual feel safe within that therapeutic relationship and to move in and embrace their resistance as important and honorable and a part of their process. Really important. So resolving ambivalence by evoking a client's own intrinsic motivations for change or not. And years later, I did. You know, I'm also a dialectical behavior therapist, and that's one vision that I always have with clients. Like it's always, this is all right, I'm just gonna put it right here on the table. I won't pick it up ever. You just pick it up whenever you want to, you know? It helps clients explore discrepancies between disordered behaviors and their core values without inducing shame or forcing compliance, right? We use a lot of CBT in counseling, and that's really inappropriate. Why? Because that's particularly for challenge cognitive distortion. Yes, the individuals are distorted. No, we don't want to challenge in that way. They already know. I promise they already know, right? So it's all about using MI skills to help open up the pathway. Like if maybe we to talk about this, what would that feel like? What consequence might come with this? So it's a way in which that person holds their agency and their respect and their honor. Clients with co-occurring disorders often experience deep conflict, simultaneously relying on substances and eating disorder behaviors to cope, of course, while wanting relief. I want to get better. I don't want to be separated from my family. I don't want to do the things that I am doing. I want to feel connected. But one of the most important things to know about both these disorders is that they take the place of connection. They become the person's primary relationship. Their lover, their friend, their partner. They are the person's primary relationship, which is maybe why we as loved ones feel on the outside, feel disconnected, because the disorder is the primary relationship. And so that they feel deep tied to that disorder because of safety. They want to be connected to you and to others. And then they feel deeply alone and afraid because, of course, the connection is not tangible or real. That's where the disorder thing is. And that is also where the insatiability of the disorder starts. Moving in, I keep moving in. Clinicians validate internal conflict rather than labeling it as merely denial by exploring the pros and cons of behaviors often using the decisional balance framework. Clients naturally begin to recognize their true cost of their addiction and mood disorder. Well, I mean, it's a really great sentence. They naturally do. They hopefully naturally do, right? And so usually both of these therapies, these treatments, these therapeutic processes are long. They're long because they're also, it's a funny little balance. Although the co-occurrence is high, the trajectory for treatment, they usually facilitate one another. So I use substances and eating disorders and I get sober and one, I get into recovery in one, and then the other one shoots up as a means to facilitate this recovery. And then you go back and forth and back and forth, and that's what we see. And also to kind of blend in our minds what recovery means. So in substance use recovery on the whole, it means you don't drink today, you're a winner and you're in recovery. You don't drink today, right? You can cut it out, but you can't cut out food. You have to engage. You have to engage. So it's on one hand, I have it where I stop using heroin, I stop using alcohol, I stop using whatever drugs. And on the other hand, I have to think about balance and engaging and embracing. It's a lot for our minds to do. Right? And so it really takes skill. It really takes time. And it really takes patience, and it takes a whole other therapeutic love to help a person there and feel safe. There are lots of people who get sober and stay in recovery and get well. It happens, lots of people, we just have a long way to go with that because it is extraordinarily difficult. Substance use recovery, although sometimes not linear, can really be linear, right? There's lots of resources for that. It's public conversation, we talk about it. Hey, I go to AA, I do this, it's easy public conversation. Eating disorders not so much yet. And there aren't as much resources for that. And so eating disorder recovery tends to be very non-linear. And so talk about that a little more at another presentation, but it's really important to know that that's a much more difficult line. So for us, just because of the resources, the public acceptability, the conversations that we have, it's just harder. You just have to keep engaging and find balance. It's going to be different for all of us. Again, motivational entry and cognitive behavior therapy can be integrated to help clients increase self-awareness, strengthen motivation for change, identify maladaptive thought patterns, and develop healthier coping strategies within the counseling process. And this is on their terms, right? The thing about MI is it's on their terms. MI supports autonomy, reduces shame, enhances readiness for recovering individuals with co-occurring eating disorders and substance disorder. So again, dialectical behavior therapy, not as a processing agent for trauma, but as a processing agent to help a person regulate emotion so that they can engage in deeper therapy, so that they can engage in more in processing with motivational interviewing, so that they can engage in trauma exploration. But DBT, dialectical behavior therapy, is just emotional regulation skills that have certain components that help a person say, I feel overwhelmed, I feel really afraid, I'm going to engage in behaviors And I could decide to help friends. I could decide to engage in a visualization. I could decide to utilize another coping skill that I've decided, a visualization or mindfulness or whatever other skill. I could make another decision. And so it's a way in which we help a client, which is good for all of us, for all mental health professionals in this room, is to help clients with distress tolerance, including ourselves. And so helping a client move through and tolerate distress tolerance is a way to help them live their lives on life terms, whatever they may be struggling with, but certainly with these disorders, being able to tolerate distress, so that the disorders increase with the triggers, with the distress. Well, life is life, and we have distress, and people don't act the way we want to, and days don't go the way we need them to, like a lot of life. So therapy is never about taking away any of the external. It's about creating that internal locus of control so that we navigate through life on life's terms, whatever our life is, and then feel the freedom and become sort of clear enough so that we can make choices that serve us better. And that would be very DBT language. So there's no blaming, there's no right, there's no wrong. It's just about, let's discuss what is going to serve you to live the amazing life that you deserve to live. So helps with that. Family members, right? So this is whether we're family members, whether we are counselors, helping family members learn about eating disorders. So kind of what we talked a little bit about today, a little bit of psychoeducation. Normalize it. It's a brain disorder. It's not a character. It's not a choice. It's a brain disorder that a person can recover from. That is the truth. Use compassionate, non-judgmental communication. We as clinical individuals need to know how to speak. With individual language matters. So we need to know how to engage in a compassionate, respectful way with all individuals. Avoid commenting on weight, food intake, body shape, appearance. And someone with an eating disorder is going to want to talk about those things that we shouldn't. Why? Because it's where they're, threading their anxiety, where they're threading their feelings, of course. But think about the conversations that we all have during the day. Think about the ways that people talk to us. Think about, you haven't seen someone in a long time. How do you respond to them? Think about things you say to them, right? We comment on bodies, we comment on this, we comment on that, right? So it comes naturally, it's a part of our culture. But it is up to us to change our culture, right? So that we're not powerless there. So we can change the way we speak to one another. And that's someone with an eating disorder or not. We could change the way we speak to one another, right? Prioritizing, particularly in our current environment where there's a lot of weight and body conversation all around us everywhere, too. We can change that, but as counselors, we have to change that, right? That's not an option because we can do more. Normalizing exhaustion, grief, fear, confusion, someone might be experiencing. So just a normalization of, emotions in general, like something sad happens. Well, you know what? Really, really, really normal to be sad. Like, yeah, sad. It's sad, of course, right? Grief is a funny one, like takes as long as it takes, and it looks like whatever it looks like. That's the rule. So, yeah, of course. So appropriately tying that normalization with those emotions instead of, I feel sad, this is wrong, I have to get rid of this. It's like, well, God would just sit here and feel sad. So how can we support families, right? Provide psychoeducation, normalize exhaustion, grief, fear, confusion, psychoeducate, communicate emotional validation skills, support families in reducing enabling. We are all, I'm sure, have an enabling gene, right? And we all learn what love looks like. So we all have our conceptions about what it means to be loved and what it means to love somebody and what it means to support. And it's not always the most supportive or loving way. But we have these strong tapes, right, in our hard drives that we grow up with. And it is really about shifting that and helping families and loved ones shift that as well. So with substance use disorders, sometimes love can love hard And there are no guarantees. That's the thing about stopping enabling. There's no guarantee that that's going to be the cure, or that's going to help them, or that that's going to move them into recovery. There's no guarantee. It's just the best bet that you have for it. And other behavior will help them stay in it. That's the terrible thing. So it is about choosing to be healthy oneself. So our behaviors, our actions, the decisions we make are always reflections of us. And so knowing that, changing the way in which we choose to love someone and support someone and what that might look like can actually cause us really great pain at the same time. So therapeutic support groups for family members, and I've got a list on that in another slide, is really, really important too, because everybody's going through pain. So eating disorders and substance use are family diseases. There's usually somebody else that it's presenting in some which way, gambling, eating disorders, internet, like you name it, right? It's presenting somewhere. And it's also the way in which the family is coordinated. So in family therapy, we call the person with the eating disorder or substance use, we call them the identified patient. But in no means are they the patient, right? We know, and we help the family know that it's the family unit that needs to be helped. It's everybody that has a piece of it. And really important, like for, if you're gonna work in treatment centers and practicum for internship, knowing that preparing the family is one of the most important services that you do for your client. Why? Because they're gonna go back home to that unit. And if they go back home to the same unit that they left, those systems are in place to support their addiction or their eating disorder. Now, I don't mean that the family wants that. And in fact, the family doesn't want that desperately. Everybody has an investment in those behaviors and ways in which they're really talk to them. And that's just the truth. So helping that family lovingly, compassionately, respectfully, not shamingly, look at those things in a way that everyone can change themselves to support that person's recovery, and everyone can. The way it works, right? I know that I've been in this field for a very long time, and I can't tell you, it's like takes therapy and they get them back. First, I wish I was that powerful. We're not that powerful. We don't hold any of that kind of power. And two, it's always about the system in which that person resides and lives, changing it into a system in which they thrive. So everybody's got work to do, and that's one of the most important and one of the toughest things that we do. Because it doesn't make sense to the family to twist on it. Why would it? It doesn't. And that's why education is really important. On this slide, these are a teeny little bit of resources. Lots and lots of resources out there, right? AA, NA, Al-Anon, Nar-Anon family groups, Gam-Anon, lots of them. The National Alliance for Eating Disorders particularly has a helpline. So it's a helpline. It's called, and we'll send this out, findedhelp.com. And what that will do is you can literally go on there and you can say, I want a female therapist in this area. I have this insurance. This is the issue. This is what I want. And it'll set you up completely with that practitioner, treatment center, psychiatrist, counselor that will help you in line. So it does a lot of that work. You can also call them, they'll answer the phone and they'll talk to you and they'll help you through that. A lot of NEDA will too. So there are lots and lots of organizations out there for help. It's just really, really important that you get specialized help. So our all mental health disorder clients, our counselors, want to help you. Of course, we all want to help you, but we're not all equipped for all things. Right? It's huge, right? Our field. So we're not all equipped in all things. So you really want to find someone who specializes in this. And for us as counselors, mental health counselors, if we're not equipped in it, then be versed in how to talk and how to refer and how to find out. It's the same as any kind of cultural competence that we all have to have. It's the same thing. So lots and lots of that. We have the suicide crisis hotline on there. Why? Because suicide is hot, has a high rate, and particularly for substance use and for anorexia in particular. Why? Because of the hopelessness, right? The hopelessness and the shame and the aloneness and the darkness that a person gets to. Also, dietary deficiencies. If you don't eat sugar and carbohydrates and protein, your brain actually won't work. So I'm not a nutritionist, I'm not gonna go any further down that lane, I'm gonna be out of scope here, which brain won't work. So a person who hasn't eaten can't actually navigate themselves, right? Literally can't navigate themselves because their brain isn't working. First thing I ask clients when they come into my office, like I have anxiety and I'm this and I'm that. First thing I ask, and I'm not screening for eating disorders, is like, what's the last time you ate? Right? What was your day like? Right? You might have anxiety, or you might just have sporadic eating habits, where you're not giving your body and yourself what you need to actually function. Right? You ever get really, really hungry and you stand in front of the refrigerator and you're like, man, there's nothing in there, but it's full. Right? It's your brain, not the refrigerator. Right? It's the same thing that it perpetually feels. So resources there. I'm always going to provide more. I'll always talk to any of you at any time. You can always contact me. I'm always available. As I said before, treatment team approach. I know I'm running close to the wire here. Treatment team approach always for this, right? For mental health counselors out there, you are not a nutritionist. You can talk to them about going to nutritionists, why you don't want to go to nutritionists, the importance of a nutritionist, but you cannot give nutritional advice that's out of scope. Same with psychiatric or medication. So we need a treatment team approach higher and higher levels of care at times too. We need to be able to discern that. Implications for counselor education, really important for all of us. I would like to see it integrated. If you're in one of my classes, it already is integrated. And we will talk about it, but we all need to be thinking about it for sure. Regardless of specialty area for all of us. Key takeaways: co-occurring eating disorders require integrated trauma-informed treatment, culturally inclusive treatment. Counselors play a significant role in reducing stigma and supporting recovery. Families and loved ones are essential. Community education and counselor training are critical. So that's talking really fast. And I just want to say thank you so much for being here. I'm always available if anyone wants to talk about it. Oh, yeah. Oh, question. I was gonna leave it. Okay.
So I just want to say thank you, Dr. Valente, of course. I know we gave a round of applause, but if we want to do another one, just to show her she's a triple of love. So let's get it. Yes, you
I
are.
live here.
So I have one question from Zoom that says, how do I recognize that I have an eating disorder or that someone has one or is developing one?
Love that question so much. And mostly it's, you know, there are lots and lots and lots of resources, like you can go online and do you have an eating disorder, right? And really those aren't ethically or professionally sound. Most important thing is to see a professional and to talk to them about that, or to call one of the organizations or resources. There are also resources for eating disorders exclusively. There's Eating Disorders Anonymous, which is free. Always want to find support that is free. There's a lot out there, online and in person. So mostly professional. There's also an EDA has what's called a big book, which is like Alcoholics Anonymous big book. And you can pick that up and you can identify with maybe the stories that are in there for people that are recovered or recovering themselves as well. So not yourself, in other words, but reaching out for support.
Perfect. Does anyone have any questions in the room? Okay, so let me walk over right here.
This may pertain more to younger people than myself. Today, it seems like there's such an emphasis on exercise for health and also eating organic and special foods for health. When does that cross the line and become an eating disorder?
I love that question. So pertinent to all of us in all ages, my age, all of it. An addiction or an eating disorder, a disorder becomes a disorder when it crosses a line where it starts taking up more in life than a person desires or needs. So it starts, I should take my son to soccer, but I'm gonna go to the gym. I know that I'm hungry and I've got other things to do, but I'm gonna work out. There's nothing in the airport to eat besides that slice of pizza over there, but I can't possibly eat that, so I'm not gonna eat it. It has to do with the decisions that we make and how those decisions may be hurting us and how much of our life it is actually taking up. And also how much it begins to take up in our heads and our hearts and separate us from those we love, the things that we like to do, or even our responsibilities in life. So it would be the same. So it starts to move a person into a place of isolation where that eating disorder becomes the most important threat. So that eating organic food or healthy food, or if we're talking about orthorexic, will become the most important, or eating certain things, or exercising will take precedence, whether or not I have time, whether or not it's available, and to a point of exercising this time and this time. So it's balance. That's such a good question. Thank you.
Firstly, I want to say that this was a very informative and insightful presentation, so thank you for your time and effort. Coming to my question, something that really struck with me was when you said the first relationship that people who go through this disorder, the first relationship that they have is with this disorder. So how do we deconstruct that relationship and bring it more like positive or something that they like into their life?
I love that. You mean the first relationship with the eating disorder? Yeah. And sometimes it's with substance use, like eating disorders can present any time in life. You know, my age, older than me, like it can present any time in life. Quite honestly, and so can substance use. And so we're not gonna deconstruct it because it doesn't exist in a person's cognitive property, right? So deconstructing is a cognitive process. So we wouldn't necessarily think about the disorder. We would think about what's underneath the disorder. So is there trauma that a person is trying to navigate? And so in that sense, we would deconstruct because we would move underneath the disorder. Coping skills are useful and important, DBT, things like that, but only in as much as they emotionally regulate so that you can actually do some processing. Otherwise, you just switch emotions. That exactly is what the dual emotion is. Like if I go to AA and I'm sober and I'm doing this, and then I'm acting out of my eating disorder, right? So if it's back and forth, so it wouldn't be replacing a coping skill, but it would be replacing a coping skill while processing what's underneath. Does that make sense? Okay, that's such a good question. I love that.
Hello, everyone. My question is there a correlation between the addiction and the eating disorder? Because I found where I've seen people stop doing like a specific substance and then now they're harnessing in on overeating is there a correlation between the two?
Yes. So, yeah, so a person will, you know, there's certain drugs and alcohol are associated with certain eating disorder behaviors. That's true, right? Because there's a purpose there. And so say a person stops drinking and then they start utilizing binging behaviors. So binge eating disorder would be an eating disorder that is not directly correlated with body image. It's a behavior because that has to do with a couple of things. I'm not a psychiatrist, I'm not a nutritionist, but really simply without getting out of scope, when you eat certain things that people tend to binge on, it actually does raise a serotonin level that they feel better. So they are eliciting a chemical response that they would in substance as well. But then you have a kickback, right? You always have a kickback with stuff. And so that often occurs, but again, it's always going to be what's underneath that. So it differs in the sense of to engage in therapy, person actually usually does have to stop the substance, right? If you're doing heroin, we're not going to do a lot of therapy. If you're actively doing that, then that doesn't mean we won't engage in therapy, but we're going to try to get to a place where we can have some, at least with medical assistance, something so that you can do that. Otherwise, when I push, what's going to happen, right? I'm going to push here. That's not the case with eating disorders, right? oftentimes individuals are actively engaging in those behaviors. So they are intertwined with mechanisms, right? Neurological mechanisms, but also behavioral and the precepts of what's underneath the behavior. They're particularly complicated, right, to treat, which is why people die. Not just because of the disorder, but because they're complicated for us to treat and we miss it. That's the truth. So thank you so much.
Thank you very much for your presentation. You raised so many questions. My head is just swimming. But one in particular is, since the age of COVID, a whole online counseling community has developed. And I don't know if it's good or not. But I see a lot of people going in that area because it's quick, it's easy, I'm at home, and insurance covers it, so I don't have to leave, the couch potato therapy. Also, pharmaceuticals, medicines that come into play here with helping people. Sometimes, they give them like a lot of different medications that aren't really addressing the issue. And I have found, and I need your help on this, because I don't know in your program if your team approach is such that you coordinate psychiatry with psychology, so that the person who's prescribing is communicating with the person who's providing the therapy, and like it's a whole team approach. Is that something that's happening? And I didn't see it happening on the internet.
Yeah. Gosh, that's such a good question, right? You just picked so many, and they're so important, right? They're so important. And so, yes, post-COVID, we all do telehealth. Pre-COVID, you had to come into my office. Post-COVID, you're not actually going to come into my office. If you're going to, everybody wants to be in their pajamas with their coffee. I got it, right? So do I, right? Sometimes. So we all engage in telehealth. That is true. And so we've all had to learn new skills. Telehealth is a really different skill than in-person counseling. It's different, particularly with eating disorders and substance use, because one thing we need to do as mental health professionals is gauge safety. I need to be able to gauge safety. And so I need to see, the person, body language, everything you can think of with it. I need to be able to see that. So that is different. However, in the same breath, we all do engage in it. That is true too. I won't see someone without a certain safety mechanism unless I see another person, if I'm seeing them from certain things. But many, many, many professionals do, and it is safe. There are also some very reputable professionals, MDs, DOs, LMHCs, who have designed programs that are online, which I think you're referring to. And they have a good reputation, and they help, and they do gauge safety and discern whether a person is appropriate for their program or not. Do they miss things that we wouldn't miss in person? Probably. Do we miss things in person? We do. Right? So it's very imperfect. It is getting better than it was, but you're right, post-COVID, a responsible clinician is always going to have a team with an eating disorder client, should have for substance use as well. You need a psychiatrist, you need a nutritionist, and you need a therapist and a medical doctor, because you need to be monitoring everything. And so what did I just do? Did I just cross up some dollar signs here? Who can afford it? Right? But a true team, that's what a true team looks like. That's why as clinicians, we want to avail ourselves as things like, if a person has insurance, excuse me, things like partial hospitalization or IOP or residential. Why? Because the teams are there and they can get all those services. So that's what's important too. But so those are really, really important things that you brought up. But 100%, we need to have a team approach. I'm going to take a little, because I have a habit of always in the last worst places. I'll start coughing.
So we have one more question while you finish, just so you can.
Thank you so much for this very interesting presentation. I am not a mental health counselor or physician, but I do, I have clients that I'm on the nutrition side. So this is very interesting to me. And I do have a couple clients, but one in particularly that has kind of stepped away from his coaching with me coaching him because I think he's been binging. And he's shared with me, he's disclosed with me that he's recovering alcoholic, 6 years in, going to meetings and so forth. And that control piece that you mentioned, like something that they need to control, he's got some trauma and so forth that he's also shared with me. So my question really is, I know that I don't step out of the scope of what I know I can assist with and what I can just talk to him about. But how can I kind of pull him back in to perhaps approach the conversation in this safe space because he has shared needs. I could feel very comfortable talking with you, very, very comfortable with you coaching me. But I noticed that he's kind of stepped away and even our communication has kind of fallen away. So I'm assuming that maybe there's some shame, all of those feelings that are coming about. What would you suggest that I can say to him just to encourage him to, if it's fine if he doesn't want to continue coaching, but how can I help him just maybe go over one more step to either see someone about something or not?
Sometimes the most important thing to do for clients, coaching clients or mental health clients, is resources. Resources. We are never responsible for someone getting sober or someone better. Never. Not that powerful, right? I can help someone along the way. We could do harm. But we really want those resources. So if he's recovering, hopefully has a program for AA and bias for alcoholism, but we really always want to help that person in the way of not pushing. So again, that motivational interviewing. So, in that conversation, like, are there ways in which you can visualize being healthy? Are there ways that it's not working for you? Talk about, those kinds of questions. But maybe even just offering resources, and sometimes just saying, I'm here, I'm here, I'm safe, and I'll offer this to you, and here are some resources, and you just let me know. And sometimes that, and as we know, anyone that's worked with these populations, sometimes we have to watch that person fall. These are the highest mortality rates of any psychiatric disorder. So sometimes a person is going to have that. So, reminding them that you're there and it's worth it, and deserves to be happy and thrive, right? It could be a part of that journey. And then just offering those resources, PDA, AA, right? 3 support groups, things like that. And that's hard, right? And then support for you, right? Because it's hard. It is hard for us. Of course it is. Of course it is.
Well, thank you everybody in the room. I know we had some questions on Zoom, so feel free to send them over to alumni.nova.edu and we can go over and send it over to Dr. Valente and she can share awareness or any help you need when she can. And then I want to bring up Dr. Melanie Irusi and Dr. Carlos Perez. And Dr. Valente, please stay up here. Please stay right here.
Stay like you
Yes. And here you go.
She's trying to run away. So, Dr. Irusi, we have a little gift for our speaker.
Shark.
It's a special shark.
It's a special shark.
And we have sharks for everyone.
Aw.
Yeah, we wanted to recognize Dr. Valente's time and generosity, not only here today, but ongoing in the Department of Counseling, also the education, the clinical service. Of course. Thank you.
Thank you.
So we do have sharks for everyone. And as for those of you joining in Zoom, I'm throwing a shark to you. One of the things that we designed for it is Mental Health Awareness Month, and we decided to honor a scholarship that is an endowed scholarship. We want to contribute that Dr. Valente graduated from that program. So, and you've written a number of letters of reference for that, correct?
Recommendation for students, 100%, yeah.
And we have a number of students in the room. And so I encourage you to give $5 and just scan here. And thank you for joining us today.